Welcome everyone to this masterclass on thyroid eye disease. I'm Tamara Wignansky-Jaffe, President of IPOSC, the International Pediatric Ophthalmology and Strabismus Council. Let me tell you just a few words in short about IPOSC. IPOSC unites 93 national and supranational member societies, and we're growing all the time. IPOSC leads global initiatives in pediatric eye care from education to training, such as local orthoptists in Africa, through programs such as IPET to advancing premature eye care across that continent. We also champion worldwide vision screening, research, emerging technologies, and policy and treatment initiatives in myopia. As we receive no membership dues, our work depends entirely on donations and sponsorship and the goodwill of many of you, many orthoptics and ophthalmologists. So I'd like to extend a heartfelt thank you to Dr. Fisher for sponsoring this webinar through their eye hygiene products, to Dan from the American Academy, who gives us this wonderful platform. No other platform can match this one. And to all our speakers, and especially the entire IPOSC team for making today's session possible. This webinar also offers simultaneous translation, so if your region would benefit from similar support in future sessions, please let us know, and we'll be happy to explore how to provide this to you. And now it's my pleasure to hand over to our moderators and thank them. Dr. Rosario Gomez de Liaño and Giovanni Marcon. Thank you, and Giovanni, please start.
Thank you, Tamara, and good morning, good afternoon, or good evening, depending on which part of the world the attendees are. I am Giovanni Battista Marcon. I am an Italian strabismologist and former IPOSC secretary, and I will moderate this webinar today together with Professor Rosario Gomez de Liaño from Spain. I don't think Rosario needs any presentation by me, but anyway, she's now serving as IPOSC vice president, and she was ISA and ISA president in the past. We have today a very distinguished panel of speakers. Next slide, Dan. And first of all, we have representing the 4 continents. Representing Europe, we have Dr. Anja Eckstein from Essen, Germany. She is a very well-known, one of the most experts strabismus surgeon in TED in Europe, and she will speak about evaluation prior surgery and the use of tutor patch. Representing South America, we have Lucrecia Berganza. She is a fellow of a very famous strabismologist of the past, Dr. Arthur Jampolsky, and she's now working in Mexico City in one of the most busy orbital units in South America. She will speak about how to avoid overcorrection in strabismus associated to TED. And then representing Asia, we have Miho Sato from Japan. She's a professor of ophthalmology at the Hamamatsu University School of Medicine. And she's one of the most expert adult strabismus surgeons in Japan and in thyroid eye strabismus. She will speak about when and how to consider reoperation in strabismus surgery. And last but not least, we have representing North America, Hilda Capo, working at the Bascom Palmer Eye Institute in Miami. And she will speak about a very particular and new topic, which is surgery of strabismus surgery in patients that have been treated with Teprotumumab. I think we have a very distinguished panel of speakers. I want to say only one word to all the attendees. Please do as much questions as you can. You can write the questions in the question and answer box. Discussion is the most important part of our webinar, so we encourage you to pose really a good amount of questions. So I will give the podium to Anja for her first presentation. Please, Anja.
So, hello everyone, good morning. I'm in New York in the moment, so I think I'm joining this internationality of this consortium. So my first talk is about TED strabismus assessment. I will just start my watch. And with the first slide, I would like to explain you what is restriction. You see here a patient with medial rectus and inferior rectus fibrosis due to thyroid eye disease. And what you can see is she can't elevate and she can't abduct. So restrictive motility impairment means reduced elasticity and normal or increased contractility. The squint increases against the direction of pull of the muscle, and we have large incompetences if there's only one eye muscle affected, and you see the structural changes in imaging. And the more asymmetry you have, the more difficult is the strabismus surgery, and the main aim of surgery is symmetry of eye movements. And here you see the asymmetry. And usually squint surgery is done at the inferior and the most common at inferior and medial rectus, because these are the most common affected muscles. And the timing of surgery is very important to assess. And you have to finish medical treatment. And when you have applied the traditional therapy like immunomodulation and orbital irradiation, you usually wait 6 months until you have stable disease and controlled thyroid situation. After Teprotumumab, you will hear this today from the other speakers from Baskin Palmer Eye Institute, you may have to wait a little longer. And then you have to care for a certain sequence of surgical steps. So you have to start with decompression first, because decompression can influence the alignment of the eyes, especially when you do medial decompression. Then you can cause an abduction deficit and increases aesotropia. And if you have an inferior decompression, this can induce in cyclo A pattern. There's a very nice publication from the Amsterdam Orbital Center, which was recently published, and also other speakers from the Mayo Clinic have published on this. The aim for the squint A surgery, the main aim is to restore straight gaze, PC distance, and reading, because you all know that the straight gaze is very important, for instance, to drive a car, and the field of binocular single vision and down gaze is very important for daily routine. And you have to measure, therefore, in reading precision, including in cyclo, and I will tell you, including cyclo, and I will tell you why in a minute. When you assess a patient prior surgery, it's always good to look at available imaging to see which muscle is affected, because this is usually the muscle you address first with surgery. And of course, you measure the squint angle in primary position, as you usually do, and you perform prism adaptation. And in more complex situations, especially, you should measure the squint angle in 9 direction of gaze, including the cyclo. And you can do this with different devices like the tangent screen, Maddox Glass, or the HASC chart. And you should also measure the field of binocular single vision, especially when you plan to do eye muscle surgery in patients with no diplopia in primary position. You have to see which area of the field of binocular vision you would like to restore. And there are also assessments need to be done intraoperatively. But first, before you do your plans for surgery, you have to decide which anesthesia you could choose. There are several possibilities. You could do also in a local topical anesthesia, but if the patient is not so brave enough, this is another option. It's a subtenual anesthesia. You have only to install 2 to 3 milliliters of anesthesia solution, and you have an immediate effect of analgesia and motility left, so you can still evaluate this intraoperatively. And then when you usually, that's the most common patient to do the surgery. It's a patient with a single muscle affection, the inferior rectus is enlarged, and you have a hypertropia of the left eye. Then the main strategy is to improve the elevation on the left eye with an inferior rectus recession, and if that's not enough, you may lower the other eye. So, but for that, how to decide what to do? You would ask me, why do I decide inferior rectus recession 7 millimeters? And therefore there are more assessments needed intraoperatively. So you do an intraoperative traction test, and you dose your muscle recessions according to the intraoperative passive motility. You can also dose it according to the active motility when you do the surgery under topical anesthesia. What is nice to have, and I learned this from Jonathan Holmes, is that you mark your cornea, that you can watch the changes of cyclo intraoperatively. And if there is no, if you do the surgery under general anesthesia, so you can only use the passive motility, but then you can also keep the dose effects in mind. And in inconclusive cases, everybody knows of us that we have to then to do one step after the other. Just one more word for the intraoperative motility testing. So you test the passive motility prior disinsertion of the muscles, and you see the abduction deficit and the elevation deficit, but you test it again after you have detached the muscles. And then you see here that you have a depression deficit too, because here in this patient, also the superior rectus has some fibrotic changes. And this tells you that you should not recess the inferior rectus too much. And here you see we just adjust the tutu patch and with the intraoperative motility testing. So, and when you then have done your first step, usually after inferior rectus recession, you have an 80 to 90% good alignment, and you just finish with one muscle surgery. That's it. But sometimes the patient is not happy. And then you have to assess the situation again. You have to find out if you have done too less, then you have diplopia in upgaze, or if you have done, and then the strategy is, maybe you can follow other strategies as well, but my strategy is then to lower the other eye. And for that, you have the superior rectus recession and the inferior oblique recession available. But you know, this depends on cyclo. And if you have done too much, you have diplopia in downgaze. And then you could bring the other eye up. And for that, you can do an inferior rectus recession on this eye or an superior oblique recession. But what do you need to assess to make these decisions? And I will tell you, this depends on torsion. So after a first step, you have an 80 to 90% alignment, but on the other situation, the ones who are not happy, you could have done too little or too much. If you have done too little, you have still diplopia and upgaze. If you have done too much, you see it in the field of binocular single vision, you have diplopia and downgaze. But then, to choose the right muscle for the next step, you should measure cyclo. And if you have X cyclotorsion left, you could go, when you have done too little, and you would like to bring the other eye down, an inferior oblique recession. If you have in cyclo, you choose the superior rectus recession. And especially when you have this situation, and you may have overlooked that there is a fibrotic muscle also on the other side. And when you have done too much, so you have diplopia and downgaze, so you have now end up with a hypertropia of the operated eye, and you have an encyclotorsion, what you may have after inferior rectus recession, then you can go, if you have just a small squint angle left, for the superior oblique, especially when you have encyclo A pattern. But when you have a larger squint angle, the dose effect for the superior oblique is very low. You go for maybe an ipsilateral superior rectus recession, or you can do a revision on the inferior rectus. But if you have an X cyclo, you go for the other side, inferior rectus recession. And when you have a depression deficit, you may have advancement of, but you will hear this in the revision part of this session today. So if you have too little in this patient, I would like to show you the results of the tangent screen. Then you look at the results of the tangent screen. It's very nice. In the tangent screen, you have all the squint angles in 9 directions of gaze. So this is left, this is right. And then you see easily you have the highest deviation in left up gaze left. So according to the inferior rectus fibrosis, left up gaze is the most important impairment. It's the direction of the most impairment. Then you know that corresponds to the other side, to the inferior oblique. So you lower the right eye with an inferior oblique recession, and then you lower it a little bit, you get more symmetry, and you get a very happy patient at the end. So it's all about symmetry. So you always have to assess the squint angles in 9 directions of gaze, including the cyclo, to decide which muscle to affect and to address. And I have one patient example left. If you have here a patient with chin up, head posture, and she had an elevation deficit. There was a little asymmetry. The left eye was more affected than the right eye. Here you see the prior examination. You have a hypotropia of the left eye and marked elevation deficit of both eyes. And then you see in the tangent screen, you have X-cyclo according to the fibrosis of inferior rectus muscle. And the largest deviation is again in left up gaze. And then you know that you have to do a little more recession on the left inferior rectus in comparison to right inferior rectus. Maybe the really experienced among us would say, oh, Anja, you have just a low amount of X-cyclotorsion. You really have done the moderate large recessions on the inferior rectus. And you're right. Then the patient reported after surgery, I have made a bad trade. Now I have diplopia and down gaze. And how can you find out what is the next step? Again, you have to access the squint angles in 9 directions of gaze. And here you have the answer. In down gaze, this patient has now an in-cyclotorsion and in addition a little A pattern. So you have just done too much on the inferior rectus and you can just solve it because it's a very small squint angle with a superior oblique recession. So this is the thinking behind all the squint surgery strategies. Always measure in 9 directions of gaze and have the right timing, make sure it's restriction, and measure the deviation in 9 directions of gaze, including cyclotorsion, select the right type of anesthesia for the individual patients, and do a force suction test intraoperatively before and after detachment of the muscles, mark the cyclo position of the bulbus intraoperatively, have the published dose effects in mind, and second step should be preferably recessions and be aware of A pattern and in-cyclotorsion after especially bilateral inferior rectus recession. Thank you very much for your attention.
And thank you, Anja. And before we start the discussion, I have to announce for all the attendees if you would like to listen in Russian or to be interpreted, you can click the interpretation button at the bottom of the Zoom interface and choose either English or Russian. This is just for our Russian attendees. Okay, Rosario, do we have any questions from the audience?
No, they're not yet. I'm sure with the time there will come some.
Okay,
we have to awake them.
Yes.
There is one maybe now?
No, but yes, now.
Okay, but in the meanwhile that you read it, I have a question for Anja. We all know that we have to operate these patients in the quiet fibrotic state. And you mentioned 6 months of stability and with thyroid, let's say, okay. But it has been my experience since a lot of years that sometimes you can find patients who are classified as in the fibrotic states with a clinical classification like the CAS. But when you do an MRI with contrast enhancement, they have like a deep inflammation deep into the orbit in the muscles. And I have been treating these patients again and redoing the MRI before operating them. I would like to know if you think this is a good thing or you think it's unnecessary fundamentally.
I think it's a very good thing. And you have these 2 major manifestations in thyroid eye disease. One side is the inflammation and the activated immune system, but the other side is the active proliferation and the fibrosis and hyaluronic deposition in the muscles causes a little local inflammation, and you see this in imaging with contrast enhancement. And if you are in the good position to have imaging available and you see the muscle shining bright, we always address orbital irradiation before we are going to do surgery, and then we wait for 3 to 4 months after irradiation. So the definition is generally the squint angle should be stable for 6 months, but of course you have to look for symptoms and signs of activity and see if the activity calms down. And there are many hints to evaluate activity. Watch the antibody levels. Ask the patients, do you have the feeling the pressure sensation increases, the pain increases? So you have to do a very proper anamnesis.
Okay, thank you, Anja.
Yes, Anja, do you think the Botox has a role in thyroid eye disease?
Not on the long run, but I think on the short run, certainly, when you have a head tilt and you would like to correct the head tilt, you can inject Botox. I myself, I do not have experience with Botox, but I know that Bettina Wabbes from another German university from Bonn, she's injecting a lot of Botox in fibrotic inferior rectus muscles. But I think you have these permanent changes in the muscles and the tightened, restricted muscles, and I guess you don't get rid of it on the long run with only a Botox injection. It may be in some of the patients. You can just try it for 3 months. Why not?
Yeah, well, now we have too many questions on the chat. And as they are someone's very precise on cases that need too much time to answer, I'll invite you to answer them. And also because some others overlap the next panelists. So I ask you to go there. And the last question, because we have 1 minute left, do you have any tips, because that's evaluation, on the coexistence of myasthenia and thyroid eye disease? Can you give us your tips to distinguish or to see if we have both together?
Yeah, that's a very, very important question. And imaging is certainly helping you see if you have fibrotic and thickened muscles, or if you don't have fibrotic and thickened muscles. I always address thyroid eye disease first. So if I see a motility deficit which fits to the imaging, I correct this first. But another hint for that myasthenia has a big influence on the not alignment, on the misalignment, is that it's changing. So if it's changing a lot, you're not allowed to do the surgery. You have to treat myasthenia first. And because we have so many good new drugs for myasthenia, you should really calm myasthenia down and then start the surgery.
Okay, Giovanni, if you do agree, we can thank Anja, and we can skip over the next speaker. So, Lucrecia, can you share the slides? So the next speaker will be Lucrecia Berganza from Mexico City, and she will speak on how to avoid overcorrections in thyroid strabismus surgery. Lucrecia.
Thank you, Dr. Gomez de Liaño. Thank you, everybody. Good morning. I want to share some tips and thoughts about how to avoid overcorrection in thyroid strabismus surgery. I work in the thyroid eye disease clinic at the Instituto de Oftalmología Fundación Conde de Valenciana at Mexico City. Strabismus surgery might be needed for the management of diplopia, especially in primary and downgaze position. If orbital decompression surgery or radiotherapy is needed, it should be performed prior to strabismus surgery, as Dr. Eckstein shared with us just a minute ago. Stability of the deviation for a minimum of 6 months is recommended almost by all authors. Use of glucocorticoids, biologics, and/or radiotherapy to improve inflammation and severe orbital congestion may be needed first, in a case-by-case regime. Thyroid dysfunction and immunological status should also be addressed before surgery to avoid complications and overcorrections. What to do before surgery? Cessation of smoking and/or secondhand smoking is very important, and we have to be reliable on that with the patient. Something very important and undiagnosticated is obstructive sleep apnea syndrome, nocturnal paroxysmal hypoxia, and another causes of hypoxia should be diagnosed and treated. And it's related and worse cases of thyroid disease and worse prognosis of the surgery. As Dr. Eckstein said, extraocular muscles and orbital MRI or CT scan are very important to proper surgical planning and for using adjustable sutures if we need it. Or the general guidelines said, although reoperation rates can be as high as 50%, some tips may help achieve better results, such as recessions should be larger than usual for small isotropias, and recessions should be smaller than usual for large isotropias. Recession or restricted extraocular muscles is usually recommended, although resection might also be needed depending on the degree of the deviation and the amount of the recession made on the antagonist and on the position of the contralateral die in order to benefit from Harry's law. What should you expect? Foreduction test is an important part of the surgical moment and is needed in order to be better plan the surgery and make the dynamic adjustments as necessary. Overcorrections and undercorrections may happen in about 50% of the cases of either vertical or horizontal muscle surgeries, where the planning is made with dose response, millimeter tables, and no adjustable sutures. What about the eyelids that are very important in our cases too? When vertical muscle surgery is needed, eyelid position might change and cause further corneal exposure or cosmetic complaints for the patient. Identification and release of the eyelid retractors, especially the inferior ones, is a key component to avoiding this potential complication. Botulinum toxin or even surgery might be needed to correct superior eyelid retraction that is a cardinal sign in these patients. What about the post-op care? We are using supplementary oxygen during inflammation phases, reactivations, and after surgery, and it's shown to be very useful. This picture is a patient who went through surgery, and this is the first picture, and the left is 24 hours post-op, and the second picture at the right is 1 week post-op with 2 liters per minute during sleep. And it's very simple, but local cold application to reduce pain, swelling, and inflammation is very useful too. When do overcorrections occur? Well, some cases appear into the immediate postoperative period. The use of dynamic techniques and adjustable sutures help to prevent them. Some other cases appear late. After an initial good result, muscle and the orbital scarring causing fibrosis, further restriction, or muscle slipping may change alignment significantly, and also reactivations of the disease. So I bring to you 2 cases. This is my first case. You can see CT scan of the eye muscles of these patients. You can see the enlargement practically of all of the muscles, even the superior oblique. So this is the clinical pictures of our patients. It's a 60-year-old man with previous orbital decompression surgery with mixed diplopia afterwards. 45 prism diopters of esotropia and 30 hypotropia prism diopters. So this patient was complaining about diplopia and cosmetic and, well, very uncomfortable. Here are the foreduction test reports. We have positive, both of them. I'll show you a video later. We were planning the surgery, as it said, at a bilateral medial rectus recession, about 5 millimeters, and a dynamic bilateral inferior rectus recession, also about 5 millimeters, because there were like an asymmetry in the upgaze. So I'll show you the video. Here we are doing, you can see it's very positive, that forced adduction. And there's in the up gaze. So I'll show this video that with the inferior rectus disinserted, and it's negative. So we made the plan, and this is the result at the end of the surgery. We thought it was like, okay. But 1 week after surgery, we see an exotropia of 30 prism diopters and an adduction limitation that previously the patient didn't have. So this is an overcorrection for an excess of surgery. So what we did is 1 week later, we have a bilateral medial rectus advancement as a second surgery. There's the next day of the surgery. Now the patient's 34 months in the post-op, it's 15 prism diopters of exotropia. He does not want to use a prism because he uses the fusion Berganza, and he has no diplopia. This is our last pictures of our patient. So he's now better than in the first surgery. I have my second case. Is a male, 48 years old, with the diagnosis of OT, 4 years of clinical symptoms, treatment with methimazole and propranolol, and he's still smoking. He was still smoking at that point. He said 6 cigarettes per day. Now we think we will be more. He consults because of diplopia, wants a second opinion regarding thyroid eye disease. So this is our clinical picture of the first interview with him. This is the visual acuity, the refraction, and the intraocular pressure. So when we see the motility pictures, we can see we have a right hypertropia of 25 diopters. And when we see the images, you can see, and I want to look at them because we can see, I don't know if you can see my card, but you can see the inferior rectus very large, the superior rectus very enlarged, and on the right eye. But in the left eye, we have a really, really enlarged inferior rectus. So when we plan the surgery, we analyzed the thyroid eye disease clinic, and we said that it was a BISA1, normal thyroid profile, negative thyroid antibodies. So under general anesthesia, we found these 2 crosses of downwards on the right eye and upwards 2 crosses to the left eye. So we decided to continue with the surgical plan that was a dynamic recession of superior rectus on the right eye and recession of inferior rectus on the left eye. So it was about 4 or 5 millimeters. So we inverted the diplopia. This is the first day in the post-op. So we have an inversion of the diplopia and of the hypertropia. Now we have hypertropia 30 diopters. So we overcorrect the patient. Our surgical plan again was a recession of the inferior rectus on the left eye and inferior eyelid spacer. This is the post-op after the second surgery. He still was like very inflamed because it's the first day after, but this is a timeline. He got better after the second surgery. So what to think about? Orbital and extraocular muscles imaging are basic and very important because sometimes we have a lot of fibrosis or also in the orbital socket, not only on the extraocular muscles. The hormone and immunologic stability is basic to perform the surgery. And all the tests, the interpretive test can be positive, not only related to the muscular fibrosis, also consider the socket fibrosis. My conclusions are that these patients, we need 300 degrees panoramic vision, the clinical history, the passive force reduction test, images, and what about the target? As Dr. Eckstein said, we have to think about the goals, about primary and downgaze diplopia. Adjustable shooters are very useful, and always talk about real goals and the possibility of more than one surgery, PRISP, botulinum toxins may be needed. Always my team comes with me, so I want to thank you, all of you. Thank you.
Thank you very much, Lucrecia, for this talk. And as there are not yet any questions, I will ask you about a few things. As you said, overcorrection may come slowly over the time. You presented a few ones that they were immediate, but others come slowly. Do you have any tips to recognize, or when you see a patient on day one, do you have any tips to recognize this patient may overcorrect? Can you do something at this stage once you think they are going to be overcorrected? PRISP, Botox, or any tips for it?
No, well, I think as Dr. Eckstein just said, males, basically males who are smoking or are passive smokers, it's very, very frequent to overcorrect those patients. When you see the images and you see really asymmetric, enlargement between one eye and another, that's another very important tip to do. And what to do before? Well, we try to use botulinum toxin in cases where the inflammatory phase is right now, and we can go to the operating room. And sometimes the use of steroids. Dr. Felisa Shoquida in Argentina has a number of patients, and she puts an injection of triamcinolone at the inferior rectus. So it could be like some tips to, Hilda is going to talk about the biologics. So I think the behavior of those patients are very different when you go to surgery, and you have also experience with botulinum toxin in thyroid. And you thought us that that changed a lot, and there's less fibrosis, and we can have like a little more comfort doing our surgery. But I think this is a very basic thing to take.
Lucrecia, do you think that recessing simultaneously is a question of the chat? The medial rectus and the inferior rectus increases the chance of overcorrection, and if you program, to a residual deviation in those cases?
Well, I think after these cases and this failure, that this patient that I showed you my first case, we learned that if we recess the inferior rectus, even we have the forced duction test for the medial rectus positive, we have to be more careful and do less surgery, because it's if you do the inferior rectus, you are taking some of the adduction function on the inferior rectus, so you can easily overcorrect the patient. So if you do inferior rectus recession, do less medial rectus recession, because the adduction force of the inferior rectus too. I think that's a basic tip that we learned with some pain.
Giovanni, do we have any more questions?
We have, maybe, Rosario, we have a question which has been unanswered, which is related to overcorrection. I don't know if Lucrecia may answer. Is from Finland. Is there evidence or clinical experience that orbital radiation would cause scarring of the muscles of tissue, or let's say increase the rate of overcorrections after surgery?
Well, in our experience, the worst cases that we have is with radiotherapy, because all the orbital socket, it's with a lot of fibrosis, and yeah, the answer is yes, absolutely.
Okay, thank you so much.
Thank you.
Rosario, you have other questions, or we can move to the next speaker?
We can move, because there are plenty of small questions that can be answered, and one can watch to it, to leave us space enough maybe to appear all at the end. So let's go to the next speaker if you wish.
So it's my pleasure to present the next speaker, who is Miho Sato from Japan, and she will speak about reoperations in strabismus thyroid surgery.
Hello, everyone. Today I'm going to talk about reoperations for strabismus in thyroid eye disease. There are several options for managing thyroid eye disease. Non-surgical treatment includes systemic or local corticosteroid, radiation, botulinum toxin injection, and prism therapy. Surgery is reserved for severe diplopia, abnormal head posture, and cosmetically significant deviations. So what about reoperations? Here is a report by Dr. Huang on the incidence of strabismus reoperations in TED. They reviewed 448 strabismus cases that underwent eye muscle surgery. The overall reoperation rate was 24.8%, highest in cases involving combined horizontal and vertical muscle surgeries, followed by horizontal-only surgeries. Vertical muscle surgeries had the lowest reoperation rate. Reoperations for strabismus in TED is quite challenging. It's often difficult to decide which muscle to operate on, whether to reoperate on the previous treated muscle or on a new one. Sometimes the record of the prior surgery are unavailable. Technically, it's also demanding due to tight muscle postoperative adhesions and unclear surgical dosage. The indications for strabismus reoperations are inflammation has subsided, symptoms are stable, and the diplopia or cosmetic issues significantly affect daily life. Before the reoperation surgery, consider the following. Confirm the disease is in an inactive phase. Review previous surgical notes. Evaluate orbital imaging to assess muscle status. During the surgery, take these precautions. Expect fibrosis, adhesions, and distorted anatomy. Identify muscle carefully. Look for slipped or stretched muscles. Minimize dissection to reduce the risk of anterior segment ischemia. Handle tissue gently and avoid traction on tight muscles. I will now present an example of the reoperation where the primary surgery was performed by us, allowing us to analyze the cause in detail, and one non-operated case as well. This is a 65-year-old man developed right hypertrophy because of TED. After systemic corticosteroid and radiation therapy in 2021, he still had diplopia and requested strabismus surgery. His eye position was stable for 3 years, and the inflammation had subsided. We decided to go for surgery. In July 2024, we performed a left inferior rectus recession for 3.5 millimeters using the double suture adjustable technique. Here are the intraoperative photos of inferior rectus surgery. The hangback procedure had a high risk of unstable attachment and or rupture of the suture. We used 2 sutures. One is for fixing to the sclera, and the second for adjustment by pulling the inferior rectus muscle forward. Although the amount of adjustment range is small, this technique gives us a chance to make adjustment on the next day or 2. On the next day, the amount was good. His alignment was good, was not adjusted. And in this patient, the eye position was good, but he was satisfied with the result for a while. However, 2 months later, left hypertrophy appeared, which persisted for 3 months. Due to intractable diplopia in downgaze, reoperation was performed 5 months later. During reoperation, the inferior rectus muscle was found 5 millimeters posterior to its original insertion, with the temporal half of the muscle located backward. It was advanced to 4 millimeters from the insertion. Although we used 2 sutures, inferior rectus muscle slippage was stretching, and subsequent overcorrection can still occur. After the second surgery, he still had a small amount of vertical deviation, but he can manage it with prism glasses. Case 2. This is a 50-year-old man. He showed left exophthalmos and diplopia in March 2015. A local neurologist examined him, and suprarectus muscle enlargement and inflammation of orbit was observed on MRI. Blood exams, including thyroid-related antibodies, were all negatives. Then the diagnosis of idiopathic orbital meiosis was given. He was treated with steroid therapy in the previous hospital till July 2015. Here is his eye position at the initial visit. He had good visual acuity and 40 to 50 prism diopter of left hypertropia, and it was prominent in down gaze. MRI was repeated and subsiding inflammation was confirmed. This is a movie of the surgery on surgeon's view. The traction test showed a tight suprarectus muscle. We decided to recess left suprarectus muscle as much as possible. After hooking the suprarectus muscle, a 6 vicryl suture was passed through the muscle. I used right grooved hook to protect the sclera. Then the muscle was detached from the sclera very carefully. Then the suture was passed 10 millimeter posterior from the insertion. For having additional effect, 4 millimeter hangback was created. In total, 14 millimeter recession was performed. Postoperatively, his eye alignment was good and stereopsis improved. 6 months later, however, right hypertropia developed. At this moment, I was afraid if the suprarectus was slipped, because it was recessed 14 millimeter from hangback techniques. It may not be retrieved on the reoperations. But next month, he showed proptosis and a 40 prism diopter vertical deviation. As it is a very unusual acute progress, we repeated MRI. This MRI is showing he had a new inflammation on the right suprarectus muscle and recurrence of inflammation of the left inferior rectus muscle. We rechecked his blood, and it showed high FT3 and FT4 and very low TSH. And at this time, he was finally diagnosed with thyroid ophthalmopathy. He received a steroid pulse 2 times and radiation therapy for 20 gray, then improved the inflammation. 5 years later, his eye was stable for 20 prism diopter right hypertropia, and the second surgery was scheduled. The second surgery was performed under general anesthesia. We were not sure if the suprarectus muscle slippage occurred. Then we started to see the left suprarectus muscle first. Suprarectus muscle was located 15 millimeter from the original insertion, which was close to the intended location. Then a right grooved hook was used, and then a 6 vicryl suture was passed through the muscle. The suprarectus muscle was sutured onto the sclera at 5 millimeter from the insertion. That means 10 millimeters of advancement. Then I looked at the left inferior rectus muscle. Inferior rectus muscle was also very tight. I used a double suture adjustable technique. The first suture was fixed on the sclera at 3 meters from the insertion firmly, and the second suture was used to pull the muscle for adjustment. This is the first suture, firmly tied on the sclera. This is the second suture for adjustment, and the second suture is pulled forward. And left in bow tie. On the next day, his eye position was fine. Then the second suture was just tied firmly and cut. His eye alignment remained stable for 3 years, and TED was well controlled with medication. This case highlights how unrecognized TED and recurrent inflammation can complicate outcomes, even when the first surgery seems successful. Case 3. The third case has not been operated on yet, but it is a good example of a possible reoperation case, so I would like to share. This is a 70-year-old lady. She was diagnosed as Hashimoto disease, but no medication was given. On November 2023, she noticed a tumor on her neck and seen by an otolaryngologist. On January 2024, she was diagnosed as a papillary thyroid cancer from a biopsy of the lymph node and immediately underwent right thyroid lobectomy. Postoperatively, levothyroxine was prescribed for hypothyroidism till October 2024. Ocular history. She was treated by a local ophthalmologist for glaucoma with topical medication, and she underwent cataract surgery when she was 64 years old. On May 2025, she underwent right vitrectomy for macular hole. After the surgery, she took in a prone position for 2 weeks. After the recovery, she noticed diplopia and eyelid swelling. On September 3, 2025, she was referred to us for dysotropia. Her vision was 0.3 OD and 1.0 OS. She showed right dysotropia and small limitation in abduction both eyes. Because of the macular hole, her right vision was poor. Strabismus angle was 24 prism diopter at distance and 10 at near. She underwent cataract surgery, then the refractive error was small, but the axial length was 29.9 mm OD and 28.9 mm OS, indicating high myopia. When carefully look at her face, she showed the Limper sign, the Graves sign. It's characteristic of TED. So for her career, she started with hypothyroidism and then gradually get hyperthyroidism. And incidentally, she had vitrectomy for macular hole and diplopia noticed after the treatment. When look at the MRI, she had both components with highly myopic strabismus and TED. Her lateral rectus muscle was shifted downward, and the angle between superior rectus and the lateral rectus muscle was very large. It's a sign of highly myopic strabismus. At the same time, she had large extraocular muscles. So Teprotumumab is initiated and strabismus surgery is suspended. If esotropia remains after inflammation subsided, when to operate? Is it Yokoyama procedure or bilateral medial rectus muscle recession, or both at the same time, or staged surgery? To avoid postoperative complications, long-term careful observation, repeat MRI, and intraoperative traction tests are considered. Take-home messages. When an unexpected result occurred after the strabismus surgery on TED, slipped or lost muscle is suspected. Early operation is required. If the recurrence of inflammation was suspected, wait till the inflammation subsides. But most importantly, preoperative careful examination is the key. Thank you for your attention.
Thank you very much, Miho, for these very interesting cases. And first of all, I would like to ask you, you can have overcorrections at any case. And we were used to recess the inferior rectus and transpose them nasally. But then sometimes you have overcorrections because you have a pattern and ensecular torsion. So how do you manage the cases? When do you transpose them nasally and when you don't do them?
Oh, usually I do not transpose the inferior rectus muscle because I do not make a very large recession. But if the patient has cyclotorsion, I do the small amount of transposition.
Okay. And do you use regularly non-absorbable sutures to avoid those surgeries or in certain cases? And which type of suture do you use?
Yeah, I basically using absorbable suture because it is more comfortable for the patient. But I think I may need to know absorbable suture, but in the hospital we do not have very the suture. I don't like them because it's too large and it's not useful for adjustable surgery. So I still using 6 of Vicryl, but for the first case, the muscle was slipped. The second surgery was used for non-absorbable suture.
Okay, and in case instead of overcorrection, undercorrection, which is the role for you for resecting muscles in thyroid eye disease?
I do not prefer resection, and I prefer to do the resection or advancement of the previously operated recessed muscle, but not like to do that. The resection is the last thing to do for me.
So,
Okay.
Miho, do you use OCT to measure muscle insertion if the reoperation is in a patient that you didn't do the first surgery?
Well,
OCT or
are you telling about anter-segment OCT to measure the location of the muscle? And
Exactly.
it's useful for the horizontal muscles, but for the vertical muscles, it is very difficult to measure. One time we tried to do that for the inferior rectus muscle, for the tight inferior rectus muscle patient. Patient fell from the chair. I prefer to, I do not use OCT on thyroid patient to measure the location.
And I have another question. In reoperation, how much time do you wait from the first surgery?
Well,
you don't want the patient to be inflamed, and you told you in your presentation, but you have a fixed amount of time to wait stabilization or something like that, or?
Yeah, I usually wait for at least 6 months, but most patients prefer to wear prisms, and very small amount of overcorrection or undercorrection are not, patients do not request for surgery unless the down gaze is bothersome. So we do not have so much.
Another question. You just stimulate me another question. So you have a threshold of deviation for the patient to say we go to surgery or we use prism?
Yeah, I wait for the patient because the thyroid patient has a large fusional range, so patient can adjust for the residual vertical, usually vertical disorders. So I prefer to wait until the patient request. But in the first case, the slipped muscle or some abnormal insertion was suspected, mostly immediately or within a few months. In those cases, I recommend to do surgery.
Okay.
Okay.
Rosario, we have other questions from the audience?
Yes, we have one question about the test that we like to do, but I think it's very nice if that can be written so many other people can copy from the WhatsApp. And then one question specific for Miho, what was her preferred surgical approach on your patient of myopia and thyroid eye disease? And then we will go to the next speaker.
Yeah. It is a very good question. And maybe if the patient had the muscle became thinner and still had similar amount of esotropia, I prefer to go for Yokoyama procedure first and leave the medial rectus muscle for later adjustment, the fine tuning for the medial rectus to be preserved.
Okay. Rosario, you will present the next speaker?
Oh, yeah, I will go. So
Turn.
our next speaker, I'm very happy to announce, Dr. Hilda Capo. That she's going to speak on strabismus associated to thyroid eye disease in patients that previously received Teprotumumab.
Good day to everyone. It's really an honor and a pleasure to be here presenting at this fascinating webinar on thyroid eye disease. So I will be talking about the impact of Teprotumumab on strabismus surgery in thyroid eye disease. There's very little information in the literature, but I'll review the most recent papers or the only papers that are actually published, and I will go over a study that we did that kind of is very relevant to this topic. No financial disclosures. So as we already know, thyroid is an autoimmune disorder. So the body produces autoantibodies that target the TSH receptors and the insulin-like growth factor 1 receptors in the orbital fibroblasts and the B and the T cells. There's results in an increased production of the pro-inflammatory cytokines, hyaluronan, and the glycosaminoglycans. There is also activation and differentiation of the fibroblasts into myofibroblasts and adipocytes, and all this results in expansion of the extraocular muscles and the orbital soft tissues that we have seen in MRI images that have been shown. After this inflammatory phase, the thyroid eye disease goes into a fibrotic phase, which leads to muscle fibrosis and scarring. That's when the muscles will lose elasticity. They become thick as well, and this limits their normal function. It results in restrictive strabismus, and as we know, the most commonly affected muscles are the inferior rectus and the medial rectus muscle. So what can we do medically to treat these patients before they get to this advanced stage? So in the 2020, the FDA approved Teprotumumab as the first approved treatment for thyroid eye disease in the United States. Teprotumumab is a monoclonal antibody that blocks insulin-like growth factor 1 receptors in the orbital fibroblasts. So there were two main studies that led to the approval of this medication here in the States, and there were two double-masked placebo-controlled studies that included a total of 170 patients, and these patients received 8 infusions of Teprotumumab over 24 weeks. So they get 1 infusion every 3 weeks. So these are the results of the initial studies that were published. The most dramatic finding was a reduction in proptosis, and there was a reduction of more than 2 millimeters in 71% in study 1 and 83% in study 2 of patients that received Teprotumumab. How does this compare to the patients that were on the placebo group? Well, in the placebo group, only 20% in study 1 and 10% in study 2 had improvement of the proptosis. So this was very significant and very important finding. What about a reduction in diplopia? Well, overall in both studies, 53% of the patients that were treated with Teprotumumab had reduction in diplopia, compared to 25% of the patients treated with placebo. again, significant, and we will see what other studies have shown after this was published. So there was a third study that came from the big group, is an optic X study, and they included 37 patients that were treated for the first time. There were patients that were initially in the first two studies, but were treated with placebo. And they also included 14 patients that had a second course of Teprotumumab. So in patients with diplopia, they found that 60.9% had improvement of 1 grade or more, and 56.5% showed complete resolution of diplopia. So I want to share with you how they were grading the diplopia. So they were using the Gorman Subjective Diplopia Score. So this score is based on the patient's own perception of their diplopia, and there are 3 main aspects: the frequency of diplopia, the severity of diplopia, and the functional impact. So the way the score was obtained was adding the values for each of the 3 aspects, and the score will be resulting in a score that will range from 0 to 9. So this is a way that they were really judging the diplopia in these patients. So we decided to look at our numbers and what our experience was. So we had 28 patients, and 9 of them had strabismus evaluation before and after Teprotumumab. So what did we find? Was there an improvement in the strabismus? Well, there was a slight improvement in both in vertical and horizontal, but only the vertical deviations were significantly decreased after treatment. You can see before treatment, the mean average vertical deviation was 17.2% diopters, and this decreased to 3.7% diopters. The horizontal deviations, there was a slight decrease, but it was not statistically significant. Before treatment, 30.4% diopters, after treatment, 23.1%. We did find that most patients had improvement in the adductions. 44% had significant adduction limitations before the treatment, and after treatment, only 11% had significant limitations. What about diplopia? Well, unlike the prior studies, none of our patients had complete resolution of the diplopia. They all persisted with diplopia even after the Teprotumumab treatment. So how does this compare to other studies that have been published? This is published in 2024. They had 31 patients, and they found out at the Teprotumumab, there was a 6% diopter mean reduction in the vertical deviation without significant change in the mean horizontal deviation. So the findings were similar to ours, that there was more of an effect on the vertical deviations than horizontal deviations. They found that adductions were significantly improved in the most restricted eye, and it was in all positions in subadduction, abduction, adduction, and infadduction. In spite of Teprotumumab treatment, 35% of the patients required strabismus surgery after treatment, and they did surgery at an average of 10 months after the last infusion. So what did these authors conclude? They concluded that Teprotumumab produced a significant reduction in vertical, but not in horizontal strabismus in primary position at distance, and they did find improvement of adductions, and particularly in the most affected eye. Other papers have also looked at the change in ocular alignment in primary gaze after completion of the Teprotumumab treatment. In this study, they had 17 patients, and they found that 59% were stable after completing the treatment, 24% of them improved, and 18% worsened. So the authors concluded that most patients remained stable after Teprotumumab treatment regarding ocular alignment in primary gaze. What about this other paper? They also looked at the effect on ocular alignment with the Teprotumumab. They had 11 patients that had strabismus and diplopia prior to the treatment. And they found that there was improvement in the horizontal misalignment by 2% diopters, vertical misalignment by 2.2, and total misalignment was improved by 3.2% diopters. So they concluded that 73% had decrease in the strabismus and 46% reported complete resolution of diplopia. But the numbers are very small. Our patients had larger deviations, and that's probably we would not find such a significant change. 2% diopters may not be clinically significant, but this is what has been reported. And again, they tended to get better, not worse. Back to our study, we wanted to see in terms of the surgical results after treatment with Teprotumumab. Of the 28 patients that we have, 54% underwent strabismus surgery. The mean time between the last infusion and the surgery was 16 months. After the first surgery, 67% achieved motor success and 87% were diplopia-free. So we thought it would be interesting to compare to what has been published in the literature. And we had published a study in 2020 based on patients at the same institution treated by the same surgeons, and we'll show you the results. So we found that the mode of success after the first operation was similar in both groups. The group treated with Teprotumumab had a success rate, mode of success rate of 67%, and those that were untreated at 69%. Sensory success was greater in the treated group at 73% versus 58% in the group that was not treated. We did find that the mean preoperative deviations were smaller in the Teprotumumab treated patients. Horizontal deviations in the treated patients were 21% diopters versus 31 in those who were not treated. And the vertical deviations were 17 in the treated group versus 22 in the untreated group. So there may be an advantage to the treatment in regards that we have a smaller deviations, it requires a lower dose of surgery. In terms of reoperation rates, it was similar in both groups. So how does this compare to other published literature? This paper was published at the AAO in 2024. They had 28 patients that underwent surgery after Teprotumumab. They found that 57% were diplopia-free after one surgery. Some of them, 11% required prism glasses, 7% compensatory head posture, and 4% had intermittent diplopia, but they were functionally improved and not bothered by it. 11% of the patients required reoperation, similar to our 9%, so the numbers are pretty consistent, and most of them did pretty well after the second surgery. So what these authors concluded was the success rates are comparable to series published before the availability of Teprotumumab, and again, our findings are similar. What about the stability? And this is something that is really critically important when we do this treatment. So these authors evaluated the recurrence or worsening of diplopia after the Teprotumumab treatment was completed. They have 15 patients, and there was a high proportion, 46.7, almost half of them had recurrence of diplopia. And the mean time to diplopia recurrence was 8.8 months. So they concluded that there's a substantial rate of recurrence at the Teprotumumab treatment, and surgeons, we need to be aware of this because it is important when we're planning surgery. We don't want to do it too early, as we know there's a risk of recurrence. In terms of the rate of retreatment in patients treated with Teprotumumab, this was the biggest study that we've seen so far. There was a multicenter study with 119 patients, 1-year follow-up. So they found that the overall retreatment rate was 24%. So we have a 50% recurrence rate, a retreatment rate of 24%. They found no difference in the initial proptosis, diplopia score, or duration of the thyroid eye disease between patients that were retreated and those that did not require any additional treatment. What they did find was that age was the only significant factor for retreatment. They found that the retreated patients were 7 years older than patients who were not retreated, and that was 60 years versus 53 years of age. So we always wonder, well, how useful is this treatment and what are the risks of the treatment? And the most common side effect is muscle spasm, but probably the most serious ones are high blood sugar and hearing problems that happen in 10%. In our institution, the main reason for why patients do not complete treatment is the hearing loss. And they do get evaluated. They have a baseline hearing screening before beginning treatment to be able to monitor this complication. Just this last month, a study came out published in Ophthalmology looking at long-term cardiovascular, renal, and safety outcomes of Teprotumumab versus systemic steroids in thyroid eye disease. So this was a large study. They used a Trinex, which is a international database containing the identified electronic health records. And they did propensity score matching to reduce your bias due to confounding variables such as age of the patient, sex, and other variables. So they identified 685 patients treated with Teprotumumab and matched them with the same number of patients that received intravenous glucocorticoids, and identified 741 and matched them with oral glucocorticoids. So what were the findings? They found that the treatment with Teprotumumab was associated with reduced risk of death and cardiovascular, renal, and infectious outcomes compared to steroids. And although there was an increased risk of hearing loss, there was no difference in the need of hearing devices. So they concluded that Teprotumumab may result in fewer adverse outcomes than systemic steroids for treating thyroid eye disease. And these are the graphs. This is what they found, as you can see. all the adverse outcomes to the left were mostly related to the steroids, and the only one that goes to the right, that will be the Teprotumumab, that has a higher risk of hearing loss. But if we look at the one below, the need for hearing devices was similar in both groups. So this is important to know, and to when we advise patients and trying to decide what the best medical treatment is for them. So take-home points: Teprotumumab treatment stabilizes ocular alignment in most patients. It may decrease the vertical deviations more than the horizontal deviations. It seems to improve ductions, and I think probably elasticity of the muscle is better preserved. It resolves diplopia in 0 to 56% of patients. It varies by study. And again, I think it has to do with the magnitude of the deviation before the treatment is started. However, keep in mind that 46.7% of the patients may have recurrence of diplopia, and the mean time is 8 months. So we need to monitor them closely. And of those patients, 24% of them may require retreatment. So in spite of the treatment, there's still a significant number of patients that require surgery, and that varies between 35 to 54% in the published literature. We should wait a minimum of 8 months after completion of the treatment before strabismus surgery, as we know they may experience recurrence of diplopia. And the patients, they tend to have smaller magnitude strabismus. So this was an advantage because, again, we don't need to do these super large recessions, which may cause more limitation in inductions after surgery. Motor success, when we compare to published studies and even within the same institution as we did, the motor success and neurooperation rates are similar in Teprotumumab treated versus untreated patients. But there's a big advantage to this treatment. Thank you for your attention.
Thank you very
much. Answer any questions.
Thank you very much, Hilda. I think it's a very interesting talk for all strabismologists, as many of us don't have so huge experience. And there is a question for as the point of view of a strabismologist. And do you think it's easier to operate a patient for the strabismus when they are treated with Teprotumumab, or don't see any differences with your previous treatments? Do you change something in your surgeries in those patients? Do you have to take care about something?
I don't change anything. I think it may be a little bit easier to operate on them because the angles tend to be smaller. And I think there's better elasticity of the muscles. So I don't think the restrictions are as severe as they are in patients that have not been treated. I think something that may be important, and again, if you look at the numbers, all the numbers in all the different studies are small numbers because it's a recent treatment. I think it may have an impact on when is the treatment initiated. Because initially it was more acute phase, but it's early in the acute phase. It is before or after they develop strabismus. So I think that plays a big role in terms of what the final outcome will be. I think we saw a paper that had very small deviations. It was probably, those patients were probably treated very early on with Teprotumumab versus some other patients that may be treated later on, and there may be already more permanent changes in the muscles. But I still think the elasticity is better preserved in treatments than patients that receive treatment, and the magnitude of the deviations tend to be smaller. So that is a benefit when we are performing surgery.
Do you have any reason why it improves better the vertical than the horizontal?
No, I don't have an explanation for that, but it was what we found, and it was interesting. Another published paper, they found exactly the same. Again, the differences are small. Is on that we're seeing huge changes in the alignment. So I wonder, because vertical deviations may be a little bit smaller than horizontals initially on, maybe it makes it significant, even if it's a small change, makes it more significant. Because we did find improvement in both horizontal and vertical, but when we look at the numbers, it was only statistically significant in the vertical patients. But maybe still clinically may not be any different, even though statistically there is a difference.
Well, we have.
Did you find any difference in the muscles in patients treated with this drug comparing to the normal treated or glucocorticoids?
With the glucocorticoids and the muscles, I don't find a difference, but I don't think in our institution we don't treat them aggressively with glucocorticoids. I think, again, I see a benefit in the Teprotumumab. I think in the past we did treat some with steroids, but the muscles still were stiff and they were very inelastic. So I think there is still an advantage to the Teprotumumab. And again, now that we know even about systemic risk factors, maybe more of an indication to proceed with Teprotumumab versus a steroid, so we have an option and we have a choice. The disadvantage of Teprotumumab is an expensive treatment, but it really makes a difference in terms, particularly proptosis. And again, from our strabismus point of view, I think that elasticity is better preserved and angles are smaller.
Okay.
Thank you very much, Giovanni. Hilda, and thank you very much. And Giovanni, can you introduce our last speaker?
So we move back to the last presentation of today. Anja, can you please present your last presentation on the use of tutopatch?
Yes, I do. Sarah just says hello to Hilda. I met a colleague from Hilda here in the meeting in New York. So, yes, only 5 minutes. Can you hear me all? Are you hear me fine?
Yes, we hear you well.
Yeah, all right, good. So, yeah, it's a little bit noisy here. So, it's about tutopatch implants. And we are used to do tutopatch now for the last 10 years, and we have good experience in implanting bovine pericard into very tight muscles when the squint angles are very large. We usually do this in patients after decompression, after when they have done. So when they have dysthyroid optic neuropathy, you have to decompress the medial wall, and you usually have very thickened. I think I should have to use my laser pointer here. Yeah, so we have very thickened eye muscles, and they prolapse into the ethmoidal cells. So this is intended. When you do a medial decompression, you want the muscles to move medially, and then unfortunately, the logical consequence is that you have these abduction deficits, and then you end up with very large squint angles, and then you have squint angles above 20 degrees, and there is then a need to have very large recessions, or you put a spacer in between the muscle and the muscle insertion just to preserve the arc of contact, and then you have less adduction deficit. And here you see two intraoperative photographs. So you suture the tutopatch to the insertion, and then you cut the muscle completely, and then you do the relaxed muscle position techniques, and usually we reinsert the tutopatch 4 millimeters behind the insertion, that the tutopatch is not visible underneath the conjunctiva. And then you can end up with very symmetric eye movement. So you lose a little bit on the adduction side and you win on the abduction side. But usually you end up then with large fields of binocular single vision, which I think it's amazing for these patients with very large convergent angles. And another aspect is very interesting with tutopatch. So if you have an unabated improvement and you end up with an overcorrection, an exotropia, and here this patient had an increasing adduction deficit and increasing abduction, then you can just easily revise it, because after half a year it's replaced by a scar, and then you treat it like a usual tendon and you just resect a little bit, and then you can restore the motility, which I think is a very good aspect. So you can easily do revisions on tutopatch. Here's a little video from tutopatch. So you cut the muscle only half, because otherwise the muscle would slip back and then it's more difficult to suture the tutopatch to the muscle. Here we prepare the tutopatch, so the more smooth side, is towards the sclera, and the rough side is to the conjunctiva, and then you reinsert the tutopatch 4 millimeters behind the insertion, and you use the muscle relaxation technique for dosage, but we also apply the known dose effects I will show you later from a very recent publication of our group and the Amsterdam Orbital Center, and by the end you do just an adduction test, and then you see. And you can also use this for vertical deviation. So here you have a very large deviation, 50 prisms, 27 degrees. And you have many options, of course. You can recess and resect, but this tightens up the muscle and is usually not very healthy for the field of binocular single vision. You can do a bilateral surgery, so inferior recession on this side and superior recession on the other side. But you can also do a single muscle surgery, which is good because then you have many options left and just put an implant in. And that's what we did with that large squint uncle. So we used bovine pericard again, and we did 13 millimeters. And this is the result. So you have preserved down gaze, but you have preserved down gaze, but improved up gaze. And of course, it's always the question, if it is it success, is the down gaze preserved enough? But that was her field of binocular single vision. I think we were a little lucky in this situation. So she ended up with a very good field of binocular single vision, can drive a car and read properly. And at the end, we just did a little bit upper lid lengthening. And what I not said before is that we have decompressed her also before the surgery. And these, the last slides are 2 pictures out of our recent publication together with the Amsterdam Orbital Center and the Leiden Orbital Center. What you see here is the duction before surgery and after surgery. So you see before surgery when you have a large convergent squint, so you have only 20 degrees of abduction on average, and you win on one side. So this is the winning side, the abduction increase, but you lose only a little bit on the adduction side. And it's the same with the vertical deviation. Usually you have patients with very marked elevation deficits, and then after the surgery, you win elevation, but you lose only a little bit of depression. And these are the results in the table. You don't need to look on it very carefully. You just can read the publication. On average, the dose effects for medial rectus are very low, especially after decompression, only 2% diopters per millimeter recession. For the inferior rectus, the dose effects are very high, like for the usual inferior recessions. And for the superior rectus, we calculated a dose effect in the middle in between. And the dose effect is very low on cyclo. That's very interesting because you do not induce an incyclotorsion, especially when you do an inferior rectus to the patch. So my take homes, implant use, bovine pericard to prevent large recessions is a very good idea. We have good experience with it, can be easily revised. It has low dose effects for the medial rectus, especially very low after decompression. Medium dose effects for the superior rectus and high dose effects for the inferior rectus, and very low dose effect for cyclo. So you do not induce, when you use it for the inferior rectus recession and in cyclo torsion. And I would like to thank you for your attention again. We still think in Essen that is a hot topic. Yeah, right. So.
Thank you so much.
And yes, can I just announce we have a thyroid eye disease teaching course. I should show the slide in Essen in the beginning of March. So if you want to learn more about thyroid eye disease, come to Essen for the teaching course. Visit us on the Yogogo website.
Thank you so much, Anja. Rosario, do we have time for one question or we have to finish?
I think we have to finish, and there are plenty of questions for Anja and for this last talk. So I will advise that we just have one brief question. Anja, did you ever go back to those cases? I'm sure you are. How do you find the tutor patch?
Yeah, we have revised a few, and as I said, it's a scar. The tutor patch is not there anymore after half a year. It's resolved and replaced by a scar.
Okay.
And there are no late overcorrections. So the final result after 6 months is the final result. In my eyes, overcorrections usually occur when a patient was not ready enough for surgery. So if we have done the surgery too early, because the patient is pushing us, because the squint angle is so big, then this is a higher risk for overcorrections. But when you wait the usual 6 months, usually it's fine.
Okay. So with all of that, I think it's time to close the webinar. It has been really an absolute pleasure to have you all here, and we thank you very much for this. I think there are many tips that we are going to bring home. I would like to thank back again Dr. Fischer to sponsor this webinar. And before we sign off, I would like to announce the next webinar that is going to be on strabismus reoperations, and we are going to have an amazing good team of people from all the continents. So mark in your calendars January the 10th, same hour, same moment. And with all of that, Giovanni, we thank for being here. And thank you again for all the speakers.
Thank you to everyone. And wonderful speaking, wonderful talks.
Thank you. Have a great day.
The next webinar.
Thank you.